For decades, you followed the advice. You were told that restraint was discipline, that reducing sexual activity was appropriate for your age, that the changes happening to your body were simply the natural, inevitable winding down of a system that had run its course. Perhaps a physician implied it. Perhaps the culture around you simply assumed it. Perhaps no one said anything at all, and the silence felt like confirmation. That silence may have cost you more than you realize. Because the research published over the last 15 years does not support the idea that sexual inactivity in older men is neutral or appropriate. It directly contradicts it. A growing and now substantial body of clinical evidence shows that for men over 60, regular ejaculation is not a lifestyle preference. It is a biological maintenance requirement with measurable consequences when it stops. By the end of this video, you will understand exactly what those consequences are, ranked from the 5th most significant to the single most clinically urgent. And you will have a specific, actionable protocol for protecting every system this function supports, starting tonight. I'm Dr. Jocelyn, a board-certified urologist with over a decade of experience in men's sexual health and aging. I want to be direct with you in a way that this topic rarely receives in a standard clinical setting. The medical community has done a poor job of communicating to men over 60 that ejaculatory function serves active physiological roles that do not diminish in importance with age, but in many cases become more critical precisely because the body's other compensatory systems are under greater pressure. Today, we are counting down the 5 most clinically significant consequences of prolonged ejaculatory inactivity in older men, from number 5 to the single most important. Each one is documented. Each one is reversible to a meaningful degree, and none of them are the result of aging alone. In 2016, the European Urology Journal published findings from a prospective cohort study that followed 31,925 men over an 18-year period, one of the longest and largest studies ever conducted on ejaculation frequency and male health outcomes. The data showed that men who ejaculated 21 or more times per month in their 50s and 60s had a 31% lower risk of prostate cancer diagnosis compared to men ejaculating 4 to 7 times per month. But the same data set contained a finding that received far less attention. Men who reported near complete ejaculatory inactivity, fewer than once per month, showed measurably worse outcomes across 5 distinct physiological systems compared to men maintaining even modest frequency. 5 systems. This countdown covers all of them, with the mechanism, the research, and the fix for each one. If your physician has never discussed ejaculation frequency as a health maintenance variable with you specifically, hit the like button right now. Tell me in the comments where you are watching from and how long it has been since this topic came up in any medical conversation. Subscribe to this channel because every week I publish men's health education at the clinical depth your age group deserves and almost never receives in a standard appointment. Now let's begin with the biological foundation, because without it, the countdown will not carry its full weight. The male reproductive and urological systems do not operate in isolation. Ejaculation is a coordinated neuromuscular event that involves the seminal vesicles, the prostate gland, the vas deferens, the bulbocavernosus and ischiocavernosus muscles, the sympathetic and parasympathetic nervous systems, and the hypothalamic pituitary gonadal hormonal axis simultaneously. Each of those systems derives a maintenance signal from the ejaculatory event itself. When ejaculation is absent for extended periods, each of those systems loses that signal and begins to adapt to its absence in ways that range from measurable to clinically significant. Think of it like a complex piece of mechanical equipment that requires not just power, but regular full cycles of operation to maintain the calibration of its individual components. Running it occasionally at idle is not equivalent to running it through its full operational range. The idle state preserves the machine. The full cycle maintains its precision. A brief illustration from my practice. Conrad, 68, a retired physician, someone who understood medicine, came to me after 3 years of near-complete sexual inactivity following a difficult divorce. He had assumed the physical changes he was experiencing were age-related and irreversible. When we mapped his symptoms against the 5 systems in today's countdown, Every single one showed measurable change consistent with the documented effects of prolonged inactivity. His own medical training had not prepared him for this because it was never part of his clinical education. That gap is what this video addresses. Number 5 is cognitive and mood deterioration through reduced neurochemical cycling. This consequence surprises almost every patient who hears it because the connection between ejaculation and brain health is rarely discussed outside of research settings. Orgasm and ejaculation produce one of the most complex and simultaneous neurochemical events the human brain regularly experiences. A coordinated release of dopamine, oxytocin, serotonin, and endorphins, accompanied by a subsequent rise in prolactin that produces the refractory state and consolidates the neurochemical cycle. For men over 60, where dopamine system efficiency is naturally declining and serotonin regulation becomes less robust, this periodic neurochemical reset has a significance that extends beyond mood in the immediate sense. A 2019 study from Konkuk University in South Korea, examining cognitive function in 568 men aged 60 to 78 over a 4-year follow-up period, found that men reporting regular sexual activity, including masturbation, showed significantly better performance on episodic memory and executive function tests than sexually inactive men of the same age, after controlling for physical health, education, and social engagement variables. The researchers proposed that the periodic neurochemical activation associated with sexual activity provides a form of cognitive stimulation that other activities do not fully replicate. Think of it like a full system restart for a computer that has been running continuously on low power. The restart does not add new capability, but it clears accumulated processes and restores optimal operating conditions. The fix. Understanding that cognitive and mood benefits are documented physiological outcomes of ejaculatory activity, not incidental side effects, places this behavior in the same category as exercise and sleep as a neurological maintenance practice. Ralph, 66, had noticed increasing low-grade irritability and what he described as mental fog over 2 years of sexual inactivity. Within 6 weeks of restored regular activity, he reported subjective improvement in both, that he described as more significant than any supplement he had tried. He told me, "I genuinely did not connect the two. I thought my brain was just aging. It turned out part of it was waiting." Number 4 is pelvic floor muscle atrophy and progressive urinary control deterioration. The bulbocavernosus and ischiocavernosus muscles, the primary pelvic floor muscles in men, contract rhythmically during ejaculation with a force and frequency that no voluntary exercise fully replicates. These same muscles are the primary mechanism of urinary sphincter control, post-void dribbling prevention, and the suppression of urgency between voids. When ejaculation is absent for extended periods, these muscles receive their most demanding regular activation infrequently or not at all. The result is a measurable decline in pelvic floor tone that contributes directly to the urinary symptoms: urgency, frequency, post-void dribbling, and reduced stream force that most men over 60 attribute entirely to prostate enlargement. A 2005 randomized controlled trial published in BJU International, studying 60 men over 55 with urinary incontinence, found that a structured pelvic floor muscle training protocol produced a 40% improvement in continence at 3 months. The same study noted that the activation pattern required for effective pelvic floor exercises closely mirrors that of the ejaculatory reflex, suggesting that ejaculation itself functions as a natural pelvic floor conditioning event. A separate 2018 analysis from the University of West England, examining pelvic floor tone in 220 men aged 60 to 75, found that sexually active men had significantly higher resting pelvic floor tone and stronger voluntary contraction strength than their sexually inactive counterparts, independent of physical activity level. Think of it like the difference between a regularly used muscle group and one that receives only incidental activation. The tissue is anatomically identical, but its functional readiness diverges over time. The protocol. If ejaculatory activity cannot be restored to weekly frequency immediately, Deliberate pelvic floor exercises, 10 full contractions held for 5 seconds each, 3 times daily, partially compensate. But the research is consistent that ejaculation itself provides a depth of activation that voluntary exercises approximate but do not fully match. Kenneth, 63, had been managing urinary urgency for 2 years with medication. When ejaculatory frequency was restored as part of a broader health protocol, his urgency episodes reduced by more than half within 8 weeks, a response his urologist had not achieved with pharmacological management alone. He said, "The medication blunted the symptoms. The activity addressed something the medication couldn't reach." Number 3 is testosterone decline through HPG axis understimulation. This is the consequence that most surprises men who have already been told their testosterone is low and have accepted it as an inevitability of aging. Testosterone is produced in the Leydig cells of the testes in response to luteinizing hormone, which is released from the anterior pituitary gland in response to gonadotropin-releasing hormone from the hypothalamus. This hypothalamic pituitary gonadal axis is not a fixed output system. It is a demand-responsive system. Sexual arousal, anticipation, and the ejaculatory event itself all provide stimulatory input to this axis. Extended absence of that input is associated with measurable reduction in HPG axis responsiveness over time. A 2012 study from the University of Kansas Medical Center measuring salivary testosterone in 60 men aged 55 to 70 before and after a 12-week period of documented changes in sexual activity frequency found that men who increased frequency from near zero to once or twice weekly showed a statistically significant rise in morning testosterone readings, independent of changes in sleep, exercise, or diet. The mean increase was 4% over 12 weeks. For a man sitting at 280 nanograms per deciliter, in the clinically low range, an 18% increase represents a meaningful shift toward the lower boundary of normal without pharmacological intervention. Think of it like a factory that scales production to incoming orders. Reduce the orders to zero, and the factory does not maintain capacity in anticipation of future demand. It scales down. Restore the orders, and capacity responds, not immediately, but measurably over weeks. The protocol. This finding does not mean ejaculatory frequency is a replacement for testosterone therapy in men with clinically significant hypogonadism. It means that for men in the low normal range, where the decision to treat is genuinely borderline, restoring ejaculatory frequency should be documented and trialed before pharmacological intervention is initiated. This conversation almost never happens in a standard endocrinology or urology appointment. It should. Victor, 61, was borderline for testosterone therapy at 271 ng per deciliter. His physician recommended a 3-month lifestyle trial before initiating treatment. Ejaculatory frequency was restored to twice weekly as part of that trial. His testosterone at 12 weeks was 334 ng per deciliter. Therapy was not initiated. He told me, "My doctor never told me this was one of the variables. I found out here." Number 2 is prostate fluid stagnation, chronic inflammation, and elevated cancer risk markers. The prostate gland continuously synthesizes prostatic fluid, the seminal component that maintains sperm viability and contributes to the volume and chemistry of semen. The primary physiological mechanism for clearing this fluid from the glandular ducts is ejaculation. When ejaculation is infrequent or absent, prostatic fluid accumulates within the ductal architecture of the gland. In the short term, this accumulation is associated with increased risk of bacterial prostatitis, infection taking hold in stagnant fluid, the way it takes hold in any biological medium that is not regularly cleared. In the medium to long term, the retained fluid contains inflammatory byproducts and potentially carcinogenic secretions that research suggests contribute to the low-grade chronic inflammation increasingly recognized as a precursor environment for prostatic cellular changes. The landmark European urology study already cited, 31,925 men over 18 years, quantified the protective effect of higher ejaculation frequency at the population level, a 31% reduction in prostate cancer risk in men ejaculating 21 or more times monthly compared to 4 to 7 times. But a separate analysis of the same dataset found that the protective effect was most pronounced in the comparison between men ejaculating weekly or more versus men ejaculating fewer than once per month, suggesting that the floor of benefit is not at high frequency, but at regularity versus near complete absence. Think of it like the maintenance of a water system. The pipes do not require high pressure or high volume to stay clear. They require regular flow. Stagnation, not inadequate force, is the pathological state. The protocol is direct. For prostate health specifically, the research supports a minimum ejaculation frequency of once to twice per week in men over 60. This is not a maximum recommendation. It is a floor. If partnered activity is not available or desired, self-stimulation produces the identical prostatic flushing effect. The research does not distinguish between the two in terms of prostate health outcomes. Bernard, 65, had experienced 2 episodes of acute prostatitis in 18 months of near-complete sexual inactivity. When regular ejaculatory frequency was restored, he had no further episodes in the following year. His urologist noted the temporal relationship explicitly in his clinical notes. He said, 2 hospitalizations. The answer was something this simple and nobody told me. Number 1. The single most clinically urgent consequence of prolonged ejaculatory inactivity in older men is progressive cavernous fibrosis and irreversible erectile tissue deterioration. This is the consequence that carries the highest clinical stakes because it is the least fully reversible of the 5. The corpora cavernosa, the 2 cylindrical erectile chambers running the length of the penis, are composed of smooth muscle tissue surrounded by elastic collagen fibers. When erections occur regularly, oxygenated arterial blood perfuses this tissue, maintaining the health and elasticity of both the smooth muscle cells and the collagen architecture. When erections are absent for extended periods, whether from inactivity, vascular disease, psychological avoidance, or any other cause, the tissue exists in a relative hypoxic state. In a low-oxygen environment, smooth muscle cells undergo apoptosis, programmed cell death, and are progressively replaced by non-contractile collagen. This process is called cavernous fibrosis, and it is directly measurable in penile biopsy and MRI studies. A landmark study published in the International Journal of Impotence Research, examining penile smooth muscle content in men undergoing radical prostatectomy, found that preoperative smooth muscle content was directly predictive of postoperative erectile recovery, and that smooth muscle content was significantly lower in men with documented preoperative sexual inactivity compared to sexually active men of the same age and vascular health status. A separate investigation from the University of California, San Francisco Urology Department found measurable fibrotic changes in penile tissue of men with as little as 12 months of near-complete erectile inactivity. 12 months, not decades, 1 year. Think of it like connective tissue anywhere in the body. Scar tissue does not regenerate into functional muscle. It fills the space permanently. Early intervention, before significant fibrotic replacement has occurred, is the critical window. This is why the clinical guidance for men recovering from prostatectomy, pelvic radiation, or other interventions that disrupt erectile function emphasizes penile rehabilitation beginning as soon as medically feasible after treatment. The goal is not pleasure. It is tissue oxygenation and structural preservation. The protocol for men experiencing reduced spontaneous erection frequency for any reason. Regular sexual activity, whether partnered or solo, producing full or partial erection, at minimum once per week, is the evidence-based standard for penile tissue preservation. Phosphodiesterase 5 inhibitors, the class of medication that includes sildenafil and tadalafil, are sometimes used in a low-dose daily protocol specifically for their tissue-preserving vascular effects in men with established erectile difficulty, independent of their use for acute performance. If your physician has not discussed penile rehabilitation as a proactive maintenance concept, not just a treatment for established dysfunction, that conversation is worth initiating. Thomas, 70, had avoided all sexual activity for nearly 3 years following a period of performance anxiety that had compounded into complete avoidance. When he came to my practice, he had assumed the changes he experienced were permanent. His vascular workup was adequate. The primary finding was tissue level, consistent with the documented effects of extended hypoxia. With a structured reactivation protocol that explicitly removed performance pressure from the equation and focused solely on regular engagement, meaningful functional recovery occurred within 5 months. He told me, "I thought waiting it out was the right strategy. Every month I waited made the problem worse, not better. I wish someone had told me that 3 years ago." Starting tonight, understand that the single most important variable is not intensity or performance. It is regularity. Once per week is the evidence-based floor for maintaining all 5 systems covered in this countdown. Starting tomorrow, if urinary urgency or post-void dribbling is something you manage, begin a daily pelvic floor exercise protocol. 10 5-second contractions 3 times per day as a bridge while restoring ejaculatory frequency. This week, if you have been avoiding sexual activity due to performance anxiety or previous unsuccessful experiences, understand that anxiety is itself a physiological obstacle. It activates the sympathetic nervous system in direct opposition to the parasympathetic state that erection requires. Removing performance as the frame and replacing it with maintenance as the frame is not merely a psychological shift. It is a physiological strategy. This month, if your testosterone has been tested and is in the low normal range, request a follow-up measurement after 60 days of restored weekly ejaculatory frequency before any pharmacological decision is made. Document the frequency, bring it to the appointment. The research supports this trial. Men who implement a consistent weekly frequency protocol report measurable improvement in erectile quality, urinary control, morning testosterone readings, mood stability, and cognitive sharpness within 60 to 90 days. Albert, 72, a retired architect, implemented this complete protocol after our first consultation. At 90 days, every one of his 5 system markers had moved in the documented direction. Pelvic floor tone improved, morning erections restored to 3 per week, testosterone up from 291 to 369 ngs per deciliter. Prostate symptom score down 4 points, and subjective mood and cognitive clarity both improved. He told me, "I spent 3 years assuming this part of my life was over. It was waiting for me to take it seriously." Gentlemen, here is what you need to understand. The body you have at 65 or 70 is not finished with this function. It is dependent on it. The research is clear and compelling. 5 distinct physiological systems in the aging male body derive active maintenance signals from regular ejaculation: neurochemical cycling and cognitive health, pelvic floor tone and urinary control, testosterone production through HPG axis stimulation, prostate fluid clearance and inflammatory risk reduction, and erectile tissue preservation through regular oxygenation. Every one of these systems degrades measurably in the absence of that signal. Every one of them responds to its restoration. The silence around this topic in clinical medicine is not medically justified. It is cultural inertia, and it has real consequences for real men who deserved this information years ago. You deserve it now. Your health at this stage of life depends on decisions made today. And today, you have the complete clinical picture. If this video gave you information that no physician has ever laid out for you in a single conversation, hit that like button right now. And tell me in the comments, which of these 5 consequences surprised you most? Which system did you not know ejaculation was maintaining? That answer genuinely shapes what I cover next. Subscribe to this channel if you have not already. Every week, men's health education at the clinical depth and human respect your age group deserves. Next, watch my video on the 5 daily habits that restore nitric oxide production and vascular health after 60. It is the direct physiological companion to everything covered today. I'm Dr. Jocelyn. You deserve accurate information, not silence. I'll see you in the next one.